Now what are the scenarios where you want to do emergency operation? Volvulus, intestinal obstruction is there, that is the time. Similarly, hernia got obstructed, that is another important scenario. And similarly, if there is any appendicular perforation, the biggest fallacy of appendix is the delay in diagnosis. So the operative procedure is more simpler. So that's the reason appendicular perforation with paralytic ileus, with peritonitis, it is a surgical emergency. How about the ileocecal tuberculosis? Every case of it you want to operate, not required. If you give anti-tubercular therapy with a proper diagnosis of ileocecal TB, the patient recovers tremendously without a need of surgery itself. Now let us take up such a classical example. Surgery is only indicated when the medical therapy fails in the case of the ileocecal tuberculosis. I will give you a presentation. An Indian lady of around 35 years old with abdominal pain, a series of barium follow through was being done, and ileocecal area is the one which had been reviewed. India with barium follow through means you can forget, you can only remember about tuberculosis will be the first, second and third diagnosis also. So you can see there is a narrow segment of the terminal ileum over here. She was started on ATT after the man to everything were positive, and we are sure about diagnosis. After 1 month when it had been reviewed, you can see that the bowel has once more become little opened up from stenotic state. And by the end of the anti-tubercular therapy, her bowel was totally came out of the stenotic phase. So only if medical therapy fails, then the surgery is required in ileocecal tuberculosis. That is a very important rule. Double bubble sign, traditional question. In the case of the duodenal atresia, any duodenal web or duodenal stenosis. Intratubular germ cell tumor typically will be found adjacent to which tumors of the testis is an important question. Do you think it is another previous question? It is. It is a standard question. So if you solve at least PGI AIMS All India, your own state entrance paper, that's more than enough. You are half, at least 20 kgs weight loss will be there by the time you finish off all these things. So entrance is after all only a magic and music of these things. So pathologically you can classify the testicular tumors into germ cell tumors, seminomas, spermatocytic seminomas, embryonal carcinoma, yolk sac tumor, choriocarcinoma, etc., etc. Now all of these tumors, typically germ cell group, they have one common Adi Guru who is the source of the origin. Who is that? It is the intratubular germ cell neoplasia, otherwise called ITGCN, is the source for all these germ cell tumors, which basically got divided into their own morphologies. Now that is the reason ITGCN is found in almost all the germ cell tumors except 4 germ cell tumors who don't have ITGCN as a precursor. Who are they? Epidermoid cyst, dermoid cyst, teratomas, yolk sac tumors and spermatocytic seminoma are the germ cell tumors which do not have ITGCN as the source of origin is what need to be remembered. Now let us think you are a pathologist looking at ITGCN. How does it look like? The in situ stage of the germ cell tumor is typically confined within the seminiferous tubules, ITGCN, and typically cryptorchid testis, which is going to give origin to the germ cell tumor. If you happen to take a biopsy, you can find the presence of ITGCN within it, is what need to be remembered. So there are certain states where ITGCN will be found in a very high frequency, intratubular germ cell neoplasm, which is a precursor of most of the germ cell tumors. Cryptorchidism, any family history of germ cell tumors, if somebody has got androgen insensitivity syndrome individuals who are having their testis within the inguinal canal, and that can also show ITGCN at a very high chances. Gonadal dysgenesis syndrome, and if untreated most of them will pass into a invasive germ cell tumor is what need to be remembered. Neuroblastoma, Wilms tumor, they are the 2 malignancies. You must be doubly sure about everything, doctor. Now neuroblastoma can arise from sympathetic ganglia, or it can also arise from the adrenal medulla, as what you are able to see here. Commonly it is 22 months before the baby spends his 2nd birthday cake is cut. That is the time where you come across. It becomes a large abdominal mass with the fever because of the hypermetabolic state, and possibly weight loss could be the presenting feature. If it is an older child, then it can have a metastatic complications where it can go to the bone with the bone pain, respiratory symptoms and GI complaints can be a presenting feature. So the liver, lungs and the bones are the common areas where it will be going, and it is a vinyl mandelic acid which become high in the urine because of the presence of the excess catecholamine production by this neuroblastoma. Now the question is, you find high VMA even in FEO, also in neuroblastoma. So how to differentiate between the two? Hypertension is more often a feature of FEO rather than that of the neuroblastoma. Though VMA is elevated in neuroblastoma is what need to be remembered. Then age and the stage are the most important determinants of the outcome, and those who are younger than 1 year of age at the time of presentation are more likely to have a better prognosis, and those who are above the age of the 5 years are the ones who have a poor outcome, is what I like to underscore to all of you. Now there is a peculiar feature that is there for the neuroblastoma which can sometimes be a good news. Spontaneous regression of the tumor can occur, which is a very important feature in the case of the neuroblastoma. And if I ask you, which is the second most common solid malignancy of the childhood after the brain tumors, it is the neuroblastoma is what you have to be sure about. Now a patient presents with hemoptysis. Every case of hemoptysis you want to do lung resection. What is the common cause for hemoptysis in this part of the world, in Asia, in Indian subcontinent? Tuberculosis with a cavity is a cause. Recurrent hemoptysis, if it is there, bronchial adenoma is a cause. If these are the pathologies, surgery is not really required always. Then when is surgery required in a case of hemoptysis? Massive hemoptysis, our chief's ward round question used to be, when do you call massive? How many liters? So what we have done is in second year, by the time we entered, first year MD students we told what are all the chief's questions. So then we said the best way to take the control of the chief is you start asking questions. So that is a easier way. So another common question used to be, all wheezes are not asthma, what else it will be? Immediately your answer must pop out. Pulmonary edema can lead to development of it, congestive heart failure can lead to wheeze. Fine, your day is great for that day. So that's the reason the art of post-graduation, living as a postgraduate also requires a lot of survival skills. So massive hemoptysis, 600 cc in 24 hours is an indication for lung resection. Destroyed lung with a positive sputum, bronchopleural fistula, if you are suspecting carcinoma responsible, they are all the indications. Then relative indications is if there is any bronchial stenosis or any open cavity, and if there is any tuberculosis with empyema or atypical tuberculous infection or aspergilloma also can be a relative indication for chopping out that lung segment. Now let us go to the next question. Radical mastectomy of the CA breast, a very traditional standard question. You must know what is radical, what is modified radical, what is retained and what is sacrificed is an important question. Radical mastectomy, what we do is both the pectoralis major and minor are the ones which are removed. Complete axillary dissection is being done, and then the entire breast en bloc along with the pectoral muscles and the axillary tissue is being removed, and then from some other place you take the skin graft and then place it and reconstruct. That is what you basically do in the case of the radical mastectomy. But it is more often deforming. That's the reason they discovered modified radical mastectomy, and the breast conservation surgery is the next step. So when they want to do radical mastectomy, what are the indications is the examiner's question. It is a bulky tumor which is involving the pectoralis major muscle and also its fascia. Bulky axillary lymph nodes are there which are grossly involved, and the posterior fascia of the muscle of the interpectoral fascia also got involved. That is the indication to become much more invasive by doing the radical mastectomy. Suppose it is a small tumor, non-palpable lesion, and if there are second situation is if there are advanced metastasis, adrenals, liver, everything is showing, no use of only chopping out the breast. Then those patients who wants a reconstructive surgery, and if you want a better cosmetic results, they are all considered to be the relative, they are all considered to be the contraindications for the more invasive radical. There you have to do modified radical. Now let us talk about the splenectomy. What are the important indications? Can you tell me one cause of the splenectomy where the spleen is normal in size but you still remove the spleen? ITP is a state where no splenomegaly but still splenectomy is the treatment, because spleen is the graveyard for all those autoimmune way damaged platelets is what has to be remembered. So hereditary spherocytosis, any hemoglobinopathies like thalassemia, enzyme deficiencies with G6PD, autoimmune hemolytic anemias, parasitic infections, myelofibrosis like myeloproliferative states, CML, AML, essential thrombocythemia, polycythemia vera, they are all called myeloproliferative states. In all such scenarios, it is the splenectomy which brings the relief is what need to be remembered. Similarly, Hodgkin's lymphoma, staging splenectomy is being done in the case of the lymphomas also is what need to be remembered. Similarly, Gaucher's, Felty's, portal hypertension, splenic artery aneurysm, in all those scenarios we need to do splenectomy. Similarly, if there is any trauma and lot of injury to the spleen, another indication for splenectomy. Now in Barrett's esophagus, what do you come across, doctor? It is adeno, not squamous cell carcinoma, we are all very sure. Then what can be a trickier way of asking the question? You have got a hiatus hernia. Hiatus hernia can be of two types. What is it? There can be a rolling hernia where it can roll, or it can be a sliding hernia like this. Out of these two, which is a more often responsible for the reflux leading to the development of Barrett's, doctor? It is the sliding is the one more than that of the rolling which is associated with the reflux esophagitis leading to the development of the Barrett's esophagus is what need to be remembered. Crohn's versus ulcerative colitis, very standard driving, doctor. You have got landmarks while you are writing the entrance in Chandigarh. No surprises. Crohn's versus ulcerative. How to differentiate between the two? Typically, the intestinal wall become rubbery thick with hypertrophy of the muscularis propria with a lot of edema and inflammation is what you see in the case of the Crohn's. Now if you happen to take the barium study, how will it look like? Typically, a fissured rose thorn like ulceration is a very important feature in the case of the terminal ileum. In the case of ulcerative colitis is what need to be remembered. Then typically, I will give you a short case presentation. 46-year-old contractor presented with diarrhea. Diarrhea, dysentery, which is more common? Bloody diarrhea. Dysentery is more common, inflammatory bowel disease. There is a tenderness in the right iliac fossa, and past also he was treated conservatively. And when the barium study had been done, there is a short bowel loop displaced around the mass lesion, and there is a development of a contrast which is flowing in a small tract within that mass, which is classically a very important feature of the inflammatory bowel disease on the barium follow through. Then you also find thickening leading to fibrosis, stricture formation, etc., etc. And typically what we have seen is an example of a ileal Crohn's disease where the fistula has developed into the sigmoid colon, and that is the reason you are able to see within that mass lesion the presence of this fistulous tract, which is often a feature in the case of the Crohn's is what need to be remembered. Similarly, Crohn's also can lead to pseudo-diverticular, and typically you can find the presence of the continuity between one part of the bowel to the other part by in the form of the fistula, which are recognized by passing the barium. Now you have done the CT, you found incidentally one lesion in the adrenal, Adrenal Aloma. What do you want to do in that scenario? Always it can be a FEO, that's the reason you have to check for it. Similarly, it can be adrenal adenoma which has to be ruled out. In fact, adrenocortical adenomas which are non-functional, which are not producing aldosterone, they are the most common incidentalomas which can be found in the adrenal on imaging studies what need to be remembered. Similarly, any viralizing or a feminizing tumor of the adrenal. Adrenal is a place for production of the androgens, that's the reason a viralizing tumor can be a incidentaloma. Similarly, any medullary neoplasm, metastatic cancer, Crohn's disease, amyloidosis can involve the adrenal sarcoidosis, myolipoma, etc., etc. there. So what are the standard protocol of evaluating an incidental loma in the adrenal, doctor? Get a catecholamine, rule out the FEO. Plasma renin and rule out the adrenal cortical adenoma, Conn's disease. Similarly, cortisol level, blood glucose, etc. need to be done, dexamethasone suppression tests. And when do you want to treat? Somebody you give a diagnosis of adrenal mass lesion and ask him to go means it is a bigger catastrophe than the incidental loma itself, right? So you must decide something. Less than 4 centimeters, nothing to worry, sir. You are going to go to your graveyard along with your wonderful possessive adrenal adenoma is what you must reassure. More than 4 centimeters is the one which has got a greater risk of malignancy. That is the indication for the adrenalectomy, and never try to put a needle and do an FNAC into the adrenal mass, and always adrenals need to be imaged. What is the reason, doctor? Suppose you have a bronchogenic carcinoma patient, why do you want to image even the lower cuts of abdomen? To know whether any metastases are there. Adrenal is a one important site for metastasis for a lot of malignancies. So that's the reason you have to always look for any possible primary. A patient has got a strangulated hernia, what do you want to do? No waiting and watching, operate immediately, IV fluids replenish is what you have to do. Now carcinoma prostate gland, if you want to detect, do you want to do CT or do you want to do MRI, which is more sensitive? Do you need to do it at all? And what is the importance of the digital rectal examination and transrectal ultrasound? You have to speak about carcinoma prostate. Digital rectal examination clinically will help you to identify it. Transrectal ultrasound also can delineate, prostatic biopsy can also be taken out of it. And also alkaline phosphatase liver enzymes need to be evaluated, and prostate specific antigen are the part of the protocol of screening. Then you also need to do acid phosphatase, X-ray chest to identify the lung metastasis. Similarly, spine X-ray in order to know any blastic metastasis of the prostate are there. And MRI is not used for the diagnosis of the prostate, rather it is only for staging of a proven case of the prostate cancer is what need to be basically remembered. CT absolutely has no role, and digital subtraction angiography also has no role. Child Pukes criteria, banana, B for bilirubin, A for albumin, N for neurological status, and N for E for encephalopathy, neurological status, and nutritional status. These are all very important. So total serum bilirubin, serum albumin, INR, ascites, encephalopathy, presence or absence of it is the way by which you will evaluate in the child Pukes criteria for the cirrhosis. If it is 5 to 6 points, then it is called class A, and life expectancy it is little longer. And if it is child class C, then it is a poorer prognosis, 10 to 15, life expectancy is very less, 1 to 3 years is what need to be remembered. So this is how a cirrhosis of the liver with already development of a hepatocellular carcinoma, and this grade of cirrhosis incidentally was a class B of the child Pukes criteria is what you are able to see here. Bladder catheterization. What are the contraindication before you do that is an important question. So Foley you have to be sparingly sure about placing. Blood transfusion and catheterization in male. For that matter, anybody. These are the two decisions you have to take with a lot of sensitivity towards your patient, doctor. So that's the reason, if there is any urinary obstruction or any following any surgical procedure on the urethra, or if there is an unconscious patient, if you want to decompress the bladder, they are the indications. But if there is a stricture or if there is a rupture, they are all considered to be the contraindications, especially for doing the catheterization. Thyroid carcinoma is a standard topic in exam. Follicular has bad prognosis compared to the papillary. Now, what is good news if you found a patient with thyroid cancer detected, doctor? Optimism is telling him that you don't have bone cancer, you don't have brain cancer. Be happy that it is only thyroid cancer, because thyroid cancers are highly curable. That is the reason you must assure your patient, doctor. And most of the follicular thyroid carcinomas are slow growing, though they have a poorer prognosis than papillary, but still they have got a favorable prognosis because they are quite slow growing. They can present like a solitary thyroid nodule, the follicular carcinomas. Sometimes they can be fixed to the surrounding tissues. Now, a thyroid cancer, does it present with hyper or hypothyroidism or euthyroid, which is more common with the thyroid cancer? Generally, euthyroid state is much more common with the thyroid cancer. It is the age, it is the sex and the staging, they are the ones which decide the prognosis. If it is a female patient younger than 40 years with follicular thyroid cancer detected, they fare a better chance is what need to be remembered. Solitary thyroid nodule, if it is there, what do you want to do with that? Bigger challenge is it benign, is it malignant? You have to decide based on clinical, imagological, histological features. Solitary thyroid nodule is a challenge, palpably discrete swelling in a otherwise apparently normal thyroid gland is called solitary thyroid nodule, is what you are able to see here. Good news, majority of them are fundamentally non-neoplastic conditions. Simple cyst it can be thyroiditis, it can be a simple nodular hyperplasia of the thyroid without any malignancy happening. So that's the reason benign diagnoses are much more common. Carcinomas are uncommon, 10 out of 1 or basically 10:1 is benign to malignancy is what need to be remembered. If it is a female with a solitary thyroid nodule, they have 4 times more common in women. I mean, women by themselves have got higher chances of having it. Then especially if it is multiple nodules, one of them you are able to identify, then it is much more likely to be neoplastic. A solitary, which is a part of multiple nodules, is much more likely to be neoplastic. And nodules in younger patients are more likely to be neoplastic compared to the older people. Older people have thyroiditis, other benign pathologies rather than that of a malignancy. Though they are more common in females, the bad news is that means males have lesser chance of having it, but if they have it, they have more likely to be homing a neoplasm is what need to be remembered. Then history of radiation is important. It can also make it more likely to be malignant. Now the very important question is, if you do a radionuclide scan, if you happen to come across this kind of scan, what is this? There is an increased uptake of the radionuclide called the hot spot. If there is a hot spot, good or bad? Good, because it is more likely to be benign than that of the malignancy is what need to be remembered. Sometimes some of the solitary thyroid nodules can become autonomously functioning because the genetic mutations in them, then they can lead to development of what is called as the toxic adenoma is what I like to underscore. Finally, summarize, doctor, what are all the risk factors? Any history of radiation, age less than 20 or greater than 70, nodule size greater than 4, a male gender having a solitary mass, or if there is a family history of MEN2, or if it is a fixed nodule or any suspected lymph node involvement of the draining area, they are all more likely to be malignant than benign etiologies is one of the common question in the exam. Now a patient of breast cancer, always how to be happier in spite of all this drudgery of remembering so many things in exam. The best thing is, these are all practical things. Patient with breast cancer comes, am I going to die or live? Decide, doctor. At least you must be able to talk about that to your own cousin, right? So that's the reason at the end of preparation of our entrance, we were remembering all lot of fiction patients. Okay, this patient has carcinoma rectum, I am going to take care of him, kind of hallucination we used to go into. But when we entered MD, first 6 months we used to get all those patients in dreams. What happened to my carcinoma rectum? You have become dermatology MD, right? So that's the reason sometimes clinical vignettes, case presentations, that's how finally you have to fill your preparation time more happily and then face the entrance in a like a scientist, not like a person who is ignorant and fearful about the result. Results scroll, doctor, results scroll on any day. So breast carcinoma, good prognostic factors. Typically if the ERB-B2 become overexpressed, or if there is any mutation of the P53, it carries a bad prognosis. There are many other indicators also, cathepsin D, plasminogen activated, type 4 collagenase, metastasis suppressor gene, etc., etc. But most important is ERB2. Similarly, there are certain oncogenes, presence of them is also indicator of prognosis. BCL2, P53, HER2 new, cyclin D1, NM2, proteases, cathepsin D, tenascin C, etc., etc. Especially the HER2 new is the one, if it happens to be excessively producing or excessively expressed, it carries a bad prognosis. But why you want to do HER2 new receptor levels of a given case of breast cancer patient? Because the trastuzumab, it looks like a more Afghanistan name, so is the one which is typically, what is that place? Azerbaijan. So trastuzumab is the one, all apps are all monoclonal antibodies, rituximab, etc., etc. Those who have a HER2 new receptor expression, though they carry bad prognosis, they will be highly responsive to your trastuzumab is what need to be remembered. Similarly, those who are having Ki67 positivity have a higher metastatic potential, and those who show cathepsin D and UPA, they also carry a poor prognosis is what need to be remembered. Is there any role for staging or grading, which is more important in breast cancer? Typically, it is the axillary lymph node status which is the single most important useful prognostic indicator. And if you look at 10-year survival rate, those who have lymph node positive, their prognosis falls down very drastically is what need to be remembered. Similarly, those which are well differentiated invasive carcinomas, they have got a relatively good prognosis, especially if they are tubular, mucinous, cribriform, secretory. Whereas medullary variety carries an intermediate prognosis, and a invasive lobular and invasive ductal carry the poor prognosis. These are all standard questions in exam. Lobular carries poor prognosis, bilateral will be the lobular is what has to be remembered. Similarly, there was a grading system modified Bloom and Richardson. Why are we so fanatic in learning so many things about it? Because recent November 2007 Manchester system is used in which malignancy staging. So let us also have 1-2 comments on breast cancer, common topic. Tubule formation, mitotic count per high power field, and nuclear size and pleomorphism are the determinants of the grading system developed by the modified Bloom, which carry a prognostic value is what need to be remembered. Hydatid cyst is a very challenging scenario. What do you mean by PAIR, doctor? Full form of PAIR. PAIR is puncture, aspiration, injection, reaspiration. It is typically used in the case of the hydatid cyst. Almost it replaces the surgery as a possibility. That is the main advantage. You can see the presence of hydatid cyst in the liver the way it is sitting here. So typically here we have unroofed and evacuated by aspiration. Daughter cysts are removed after repetitive infusions of hypertonic saline solution and chlorhexidine, which is having a high scolicidal activity, is what as a surgeon you are going to take care of your hydatid cyst patient. When do you want to do aspiration? When do you want to do surgery? Examiner is seriously interested about it. If it is a non-echoic lesion greater than 5 centimeters in size, PAIR you can do. Cysts with daughter cysts with detachment of the membranes, that is an indication. Multiple cysts if accessible to puncture. Similarly, infected cysts, they are all the indications for puncture, aspiration, and then injection and reaspiration. Similarly, pregnant women, children greater than 3 years who are failing to respond to chemotherapy and whom surgery is contraindicated or refuse to get operated, they don't have confidence on you, and relapse after the surgery. They are all considered to be the indications for PAIR. Then when you should not do, non-cooperative, I don't want that injection poked into my liver. Or if it is calcified, you are able to see here a calcified hydatid cyst, you can't poke the needle through that calcification. That's the reason you don't want to do. Similarly, cysts in the brain, cysts in the bones, cysts in the spine, heart, lung, very sensitive areas, you can't do PAIR. And cysts communicating with the biliary tree within the liver, and also those which are opening into bronchi, urinary tract, and which have multiple septal divisions, contraindications for the pair is what I like to underscore to all of you. Now, Counard's classification is I think recently we discussed in November 2007 paper AIMS. So what are the various lobes, doctor? It is the lobe 1 which you are able to see here is the caudate lobe. Sometimes caudate lobe is divided into left and right. Then you have left lateral superior 2, lateral inferior is 3. Then 4 is the one which is medial, divided into superior and inferior sometimes. 5 is anterior inferior, posterior superior, 8 is anterior superior. Earlier questions used to be there on bronchopulmonary segments, torture questions. So also now you have to remember about Counard's classification, which is caudate lobe, which is quadrate lobe, and which is right lobe, which is left lobe, all these things which we already discussed. Raynaud's phenomena, what is the difference, doctor? There is a pallor which is there in the terminal parts. Typically there is a digital ischemia because of the vasospasm which is typically called Raynaud's. Emotional stress is the precipitating factor. Then collagen vascular disease is another important entity where Raynaud's can be coexistent. And Raynaud's disease and Raynaud's phenomena. 50% of those who have a phenomena will also show the presence of the disease. Then women are affected much more commonly, they are also subjected to emotional stress more commonly. And those who have migraine headaches, variant angina, they are all examples of vasospasmodic episodes. They also have a higher likelihood of having the Raynaud's phenomena. One of the options given was, do you find thrombophlebitis in Raynaud's? No. Thrombophlebitis, different story. Typically it is a varicose vein complication, any venous cannulation if we do. Thrombophlebitis can develop, polycythemia, Burgess disease, visceral cancers like pancreatic malignancy can cause migratory thrombophlebitis which is superficial. They are all different story other than Raynaud's. When you want to do cholecystectomy, already one splenectomy is over, cholecystectomy, then I think next question will be hepatectomy indications, right? So cholecystectomy, there is a Gallstone disease. Once more these are important because common decision making as a GP, general practitioner, your doctor before going to DM gastroenterology, whom she will consult? Your patient. You are the MBBS is the strongest degree. DM and all, they all suffer from some kind of probably one of my friend after MD I asked, before MD final year exam was over itself, he got DM first rank. He used to read like mad in the library. I said, why do you want to do DM? You have wonderful glamorous MD from one of the best institutes in the country. What is the secret of your topping entrance? He said, it is the threat that I am not going to make up this paracetamol, chloroquine, etc., etc. I can't sit in a OPD and practice like what you can do. So that threat made me to feel I must be little above MD or below MD probably. So that is because MD general medicine is like an emperor, like, so one of the DMs will be like a knight, so one of the emperor's knights. So he said that I love to, that threat was a driving force for me. I said generally MD final year people will suffer threat of passing MD. It will be like a pre-puerperal depression kind of phase we pass through. He said that passing MD is not an issue for me. Not getting in DM and remaining one more year unemployed was the driving force. So I want to tell you, doctor, threat is essential before exams, but that threat should become a driving force for us to, because to reach top, keep the top is much more difficult job actually, is all what you have to do. That's the reason, don't say tension. Tension is essential evil which is required at this moment. If we are not tense, then we are too patulous, which is not correct. So symptomatic Gallstone disease, if any acute or chronic cholecystitis, chop out the gallbladder. Mucocele, empyema, strawberry gallbladder and porcelain gallbladder, carcinoma gallbladder, a calculus cholecystitis also. At the time of Whipple's operation, you can give a complement package deal. Whipple's is done pancreas, duodenum and also your gallbladder. And also gallbladder polyps, they all basically require it. Now in this context I like to quickly talk about two important areas. What is this strawberry gallbladder, porcelain gallbladder and mucocele gallbladder? Which are pre-malignant, which are not? is a favorite question of the examiner. Let us be very sure about it. Strawberry gallbladder means lot of cholesterol become deposited in this, in the gallbladder. That's the reason it gets that stippled appearance, strawberry. And it is not associated with malignancy. Eating strawberries is not cancerous, right? It is a tendency, that's all. So there is no known association even with hypercholesterolemia. Another way of asking the question in the exam. Strawberry gallbladder, if you eat more ghee, will you get it? No. Then not even diabetes with hypertriglyceridemia also is not a predisposing factor. And if at all the strawberry gallbladder polyps are small, patient can be followed up. And elective cholecystectomy need to be done if it is symptomatic. One important thing that we need to worry about strawberry gallbladder is, though it is not pre-malignant, it is your duty to prove that it is not a malignancy presenting with a similar appearance. That is the reason we do the cholecystectomy, not that it is pre-malignant. But finally, whether it is pre-malignant or not, finally you are knocking out the gallbladder. So one of the indications for cholecystectomy, though not pre-malignant, is the strawberry gallbladder. To rule out any possible gallbladder malignancy is what need to be remembered.